As far as anxiety, one, check if they're fatigued or are they agitated. This could produce anxiety. Remove them from any situations that produce anxiety and help them to avoid situations that you know produce anxiety. Once again, a daily consistent routine and schedule. Rest periods. Activities that are actually quiet. If they do become confused and agitated, though, I want to remind you to always assess their physical condition. Make sure they don't have a fever. Make sure they're not hypoxic or their blood sugar is low. Hopelessness. You want to assess in the beginning their understanding of the disease process and also assess the family. Give them realistic information when they're ready. Offer support groups and encouragement. Assess their response to the diagnosis. Avoid judging when they make decisions about their care. Encourage their family bonds. Encourage them to make decisions as long as they are capable, and offer spiritual guidance. And then caregiver role strain, who's taking care of them, and teach them to take care of themselves. Refer them to local support groups and services. Talk to them about hospice or respite services that might be available in their community. These are just some additional nursing interventions for individuals suffering from Alzheimer's or dementia. On page 1458, we will talk about delirium. So how does delirium differ from dementia? It is a temporary but acute mental confusion. So a temporary but acute mental confusion. It can be life-threatening and preventable. And we just don't necessarily understand why someone tips into delirium, but we know that it's rarely caused by a single factor and that it is usually set off by a precipitating event. And so you have, for instance, an elderly patient who comes into the hospital with an exacerbation, for instance, of their heart failure, and we give them a sleeping medication and they enter into delirium. Delirium can be caused by many things. In your book, on page 1458, we see where there is a table, 60-14, that goes through different factors that precipitate delirium. So anything such as demographic changes, anything with decreased oral intake, new drugs that we might give them, environmental issues. So you can read through this chart. Again, more common in older adults. They seem to have a very febrile status that can tip them into delirium. We've already gone through the fact that there are multiple factors that could contribute to delirium. And so some of the things that happen is they have disturbed consciousness, coupled with cognitive difficulties in thinking, their memory, their attention, their perception of what's going on. And then certainly this, what is a sign, is what we call sundown syndrome, where this individual is experiencing increased confusion during the evening hours. Okay, so some of the common symptoms of delirium are listed on page 1459. You can have hyperactivity to include a change or an increase in their vital signs. They could become hypervigilant, where they're constantly alert and scanning their room like something is wrong. They could have mood swings, and they can display agitation and anger. They could lose their appetite, be restless, have insomnia. This could develop over hours to days. Typically, your book says it's 2 to 3 days. We want to distinguish between delirium and dementia, okay? And your book says a key distinction between the two is someone with delirium exhibits sudden cognitive impairment, disorientation, or a clouded sensorium. Remember that we want to make sure that we have a careful monitoring of their medical and psychological history do a physical exam, and then make sure that we pay attention to meds, both prescriptive and over-the-counter. Also, we want to look at lab tests and look at, for instance, CBC lights, blood count, possibly blood gases, liver function studies, ammonia levels, thyroid, so many different types of diagnostics that we need to look at. Okay, continued about delirium on page 1459. We need to assess. Obviously, we want to assess their vital signs, their level of consciousness, any neurological changes that they have. We want to quickly determine if they're a risk for injury and assess, do they need comfort measures? Do they need immediate medical intervention in order to prevent any brain damage? When we are looking at the assessment of delirium, there is the CAM, which is the Confusion Assessment Method, on page 1459, and it shows you what you need to look for. It shows that you need to look for the acute onset and the fact that it fluctuates. You need to look for their inattention and their disorganized thinking, and are they having an altered level of consciousness. Also, there's a mnemonic for causes of delirium in table 6015 that you guys can read through that might help you to understand why individuals would suddenly experience delirium. Okay, so when we focus on medical management, we just want to make sure that we can identify, hopefully, what is causing the delirium and fix it. Okay? Now, if you guys look at page 1460, you'll see there's a brief or a short area on drug therapy. So typically drug therapy for delirium is withheld for severe agitation. With that being said, we need to remember that agitation can actually place a patient at risk for falls and injuries, so there are times that people might need to be sedated for their own safety. Often used out on the floor are antipsychotics or neuroleptics, such as haloperidol or risperidone. Haloperidol, or Haldol, as you guys might know it, actually is a drug that's given more frequently because it can be given IV, IM, or orally. Just realize that this class of drugs produces sedation, can cause hypotension, what we call the extrapyramidal side effects, including involuntary muscle movements. So we would need to monitor for those. Sometimes when someone is having a withdrawal, let's say from alcohol or other drugs, we might actually use a short-acting benzodiazepine such as lorazepam. And lorazepam, again, can be given IV or PO. But it needs to be, these individuals need to be monitored carefully because it too can cause sedation, prolonged sedation, and it too can cause hypotension. When we're taking care of someone who's experienced delirium, it's important that we keep a quiet, non-distracting stimuli environment, that we communicate with the patient by identifying ourselves, using short, simple words and phrases, and speaking slowly, and focusing on one piece of information at a time. We want to talk to the patient about things that are familiar, meaningful in their life, reinforce reality when the patient is delusional or having illusions. Make sure that if they wear eyeglasses or hearing aids, that those are readily available, and that we use things that help to keep them oriented. I just want to say here, our long-term outcomes include that the patient will remain safe, that they will return to being oriented to time, place, and person, and that we've identified the underlying cause and we've treated it. I also want to say that, we do not jump to using restraints. We actually want to avoid using restraints and try other techniques first. And those techniques sometimes do include relaxation therapy, music therapy, massage therapy. You also want to make sure that the patient's stable, that their vital signs are stable, that they have not dehydrated and electrolytes are balanced, and that we have hopefully identified the cause of the delirium and returned them to their pre-delirium baseline status.